Hi everyone, good afternoon. Thanks for joining for Advanced Echo Teaching in the Critical Care today. It is a pleasure to introduce my good friend Shanthosh. Shanthosh is a cardiologist working with us here at Nepean, and he is also one of our PhD students doing his PhD in septic cardiomyopathy and looking at a sort of acute heart failure in the critically ill. And it's really exciting to have him as part of our sort of cardiopulmonary research program here. Obviously looking into acute heart failure, and one of my own sort of passionate sort of things, I guess, is talking about speckle tracking, and can't think of anyone better to help talk about some of that than Shanthosh.
Thank you.
Thank you very much. Got about 45 minutes, and it's a real pleasure. Thanks again for teaching us today. Thanks.
Not a problem. Cheers. My pleasure. Thank you, Sam. Thanks for the kind introduction. So I'll get started. And I'm not sure in terms of how much or understanding you guys have of strain, so I'll go through the basics and then we'll go through some of the pitfalls of doing strain and some of the clinical examples. All right, so let's see. I know that you would have loved this, Ben. All right, so when we talk about strain, we're looking at assessment of regional and global ventricular function, and in the past it's really relied on visual assessments, and this is, as you know, is quite subjective and variable in terms of how we measure them, and so as you realize that there's some cases you've got inter-observer variability as a result of that, and the reason for this is because the heart is a mechanical organ which undergoes cyclical deformation in systole and diastole, and I'll go through that a bit more in detail a bit later on. But in the past, when we talked about how to assess strain or strain measurements, we looked at tissue Doppler based methodologies in terms of tracking the movement of the muscles in a certain plane or longitudinal fashion. So as I alluded to before, that there is a sorry guys, I'll just accept people as they come in. As I've alluded to before, that there's a myocardial mechanics of the heart. It's a twisting motion, or like when you twist a towel and so forth. And what that means is that the apex will rotate in one direction, and then you've got the base that rotates in the opposite direction. And so measuring this becomes quite difficult because, well, how do you assess those measurements? And usually based on, our traditional methods of left ventricular ejection fraction, it's a 2D plane measurement of a 3D organ. So that makes it quite difficult, or it has its own inherent limitations. So when we talk about strain particularly, we measure the tissue deformation. In other words, how much does it change in the length of an object when it's relative to its original length? So imagine a slinky, extending and contracting, and that's what we're looking at in terms of how much it changes. Now, when we talk about strain rate, it's when we're talking about the rate at which this deformation occurs, and how fast this changes. And so when we look at it, or when we measure it, we talk about the velocity at the beginning minus the velocity at the end, and you divide it by the length of the muscle fiber, and that's your strain rate, how fast it changes. So, like I said, the myocardial deformation is in a three-dimensional phenomenon, and therefore echo has its limitations in terms of how we can measure it. And at the moment, we predominantly can measure it in terms of radial, circumferential, and longitudinal fashion. When we talk about longitudinal fashion, we talk about the measurements of the fibers in the subendocardial layer. When we talk about the circumferential function, it's predominantly looking at the subepicardial fibers of the heart. And the septum, as you know, is a mix of both the RV and the LV, and so therefore it's measured in terms of the longitudinal fashion. When we're talking about the longitudinal fashion, we look at the contraction of the heart or the deformation of the heart muscle in a longitudinal fashion, so up and down fashion. And it's a shortening and lengthening of that. So predominantly when we talk about shortening, we come up with a number of -18 or -20. And you're like, well, why is it minus? And I'll go through that very shortly as to how we come up with those numbers. When we look at the circumferential function, it is, again, it's a shortening function in terms of how the ventricle or the right ventricle contracts and functions as a result of that. When we talk about the radial strain or radial shortening, we'll look at how the ventricular muscle thickens and over through the course of its ventricular contraction. So, as I said, strain is a measure, or is the same as looking at the deformation, and it depends on really how it is applied in terms of how much strain there is. When we look at calculating strain, it's looking at you initially measure the length at the given point of time, minus that at baseline length, and divide that over the initial or baseline length as well, and then times by 100, and you get a percentage. So, you know, this strain obviously can be either positive or negative depending on where you start measuring. So, for example, if I look at this slinky or spring or whatever, the initial length was 5 centimeters, and if it extends to 8 centimeters and you do 8 minus 5 over 5, you get a 60% increase in terms of its length. So that's why it's positive. And vice versa, if it's the opposite, in other words, if it's contracting, then you get a negative strain number. So that's how you get a positive and a negative strain. And that depends on which way it contracts. So when we look at circumferential strain, I alluded to this before as well, it measures this twisting motion of the LV cavity. And remember that the base and the apex, they twist in the opposite direction. And that's the way that the heart essentially contracts. And so that's why when you look at it, it's a twisting motion. When we look at radial strain, we're looking at the thickening of the actual muscle. So thickening and the thinning of the muscle. And that's all, like, you know, we do this on a routine basis when we look at echoes and we eyeball it, but we can actually measure the percentage of thickening and thinning of the muscle. And then longitudinal contraction is looking at in a vertical plane as to, well, how much does the muscle actually move up and down. So remember I said that tissue Doppler imaging was the initial way that we measured strain in the past. So echo-based techniques measured deformation by either two primary methods, and both of them still exist in terms of our practice, and it's either through tissue Doppler or Speckle-based tracking. And I'll go through Speckle-based tracking very shortly. Now, in terms of tissue Doppler imaging, strain rate is the difference between velocity between 2 points along a myocardial wall, but and from an initial point of view to the second point of view. So it's comparing how fast it has moved across the plane. And so strain rate measures the rate at which those 2 points of interest move towards or away from each other. And you can understand that the limitations of tissue Doppler imaging is that it has to be in the plane of the ultrasound wave that is carried, because otherwise you won't be able to measure that velocity. So tissue velocity based strain measures tissue velocities along two locations along the long axis direction. And the difference in peak velocity is normalized to the distance between the yields of myocardial velocity gradient or is strain rate. So what that means is you look at the difference between the two measurements, and then you're able to calculate how fast or what the difference is, and then come up with a velocity gradient as a result. Now, Speckle tracking echocardiography or Speckle tracking strain is a system that tracks the acoustic patterns within the myocardium, which are termed the speckles. So when the ultrasound waves hit the myocardium, they bounce off in different ways, and those waves come up with as like you get this speckle type of appearance on the myocardium, and this is like a thumbprint or a fingerprint of the myocardium. And the AI or the software is able to recognize this thumbprint or this region as a its own identity, and is able to track those movements of the myocardium and then measure actually the deformation in terms of, well, how much has it actually changed from before and after. So now these speckles can be tracked over time, and the speckle displacement, so in other words, how much they're displaced, can be used to calculate the tissue velocity and the actual strain. Now it is relatively angle independent, so it's not really affected by how you've got the probe facing or the Doppler images acquired, because it doesn't really it's not really based on Doppler. So remember, when we talked about tissue Doppler imaging or tissue Doppler strain, it is on a longitudinal fashion. Well, in this case, you don't really it's not really affected by that. And the direction, the amplitude of the motion at various points in the heart can be actually measured. So that, as a result, then you can do longitudinal strain, radial strain, and circumferential strain. And like I said, and I talked about this before in terms of how it becomes positive and negative. So circumferential and radial strain, when we talk about the LV, are obtained in your standard parasternal short axis view at the mitral, papillary, and the apex level. And you can actually look at what the twisting motion of the heart is, and the thickening and thinning of the radial of the LV cavity or LV muscle wall. And you get this, and when we talk about longitudinal strain, we measure in a longitudinal axis, and that's acquired from the apical 2, 3, and 4 chamber views. And then you get this, they're further subdivided into 6 segments. You've got the basal, mid, and apical segments. And so you can really talk about specific segments that are affected when in strain. And so then to account for strain, we need to make sure that we time it according to the aortic valve closure. And that's best done in your 3-chamber view, because that's probably the best view in terms of timing the aortic valve closure. And it's used to define the end systole of the cardiac cycle. And sometimes if you can't see the aortic valve closure, then it really roughly accounts to the end of the T wave on your ECG as to the end of the systole. So global longitudinal strain is calculated as an average of all of these segments, and is commonly used as a measure or a marker of global LV function. And in generally the healthy population, you get a strain or GLS of -18 to roughly about -25 in the healthy population. So this is your strain in your 3-chamber, 4, and 2. And I'll go through the segments and how to acquire them very shortly, and what the pitfalls or practical considerations are when you're actually doing strain measurements in your day-to-day practice. And so when you do your strain, you get this format which displays your global longitudinal strain. So when we look at the top, you got your colors encoded, which are your region of interest, and I'll go through that very shortly as well. And then in each of those things, you can get those segments, and you can actually get segmental strain in terms of how much each of the segments vary or are affected over time. So then you come up with a bullseye plot, which is usually an 18-segment bullseye plot of each of the segments, and that will actually give you some regional variations if there are, and that can account for either certain specific disease entities, or if they've got certain areas of infarct that are affected, then you won't, you'll see a positive strain, or you won't see as quite as a negative strain as you'd expect. Now, the right ventricle, when we look at the strain in the right ventricle, it's a bit more difficult because it's thinner than the LV myocardium, and the 2 ventricles have different shapes, and it's more of a triangular shape. Now, the tissue Doppler imaging has been validated to quantify RV myocardial deformation in healthy individuals, and RV strain has only recently, in the last couple of years, been validated and been used more often in routine practice. And in the past, what has really happened, I'm pretty sure it's still the case, where they've used the LV strain package and they've just flipped it and said, we apply that same equations into the RV strain. So it's and then we take away the septum because it's shared by the LV. LA strain gets a bit more tricky because LA strain is a bit more recently more acquired, and it's gained more attraction or attention, and it can measure in terms of the different functions of the left atrium. So under normal conditions, the left atrium is quite a low volume pressure, and it's highly expandable chamber, and you can see, LA dilatation quite commonly when there's any evidence of elevated left ventricular pressures. But in the presence of acute or chronic injury, the left atrial wall stretches and stiffens. Now, the LA volume is not really as a marker of LA function, and it reflects more of a chronic changes of the LV filling pressures, but it may be increasing patients with atrial arrhythmias or in athletes whose filling pressures are actually normal. So when you look at LA strain, it provides an additional information in terms of the LA function. It looks at the atrial function, which looks at reservoir, conduit, and active booster. And so when we look at the LA strain function, it becomes a bit more tricky because the different segments or different parts of the LA strain measurements will actually tell you in terms of what function or what actual mechanics of the left atrium is impaired. And I won't go too much into detail about this because I think it's probably a topic in its own. But I think what might be more useful for you guys will be the actual practical guidance in terms of how to do strain, or what are the considerations, particularly when we do strain measurements. So when we talk about the steps in terms of acquiring myocardial strain, it's generally, these are the 7 steps that we think about in terms of all considerations of acquiring speckle tracking strain. So we need to make sure that the image is appropriate, and you've got appropriate 3, 4, and 2 chambers so that you can actually do strain measurements. And then once you do have the adequate image, to make sure that the quality is enough for actually the strain software to actually track the myocardium or the endocardium specifically. And then, making sure that certain parameters, particularly the annulus or the is not included, and the apex is not included. And when you actually trace the endocardium or the endocardial border, that you only include the endocardium and not the pericardium, because all of these things will actually affect your strain measurements. And particularly when you do the region of interest, which is the colors, in which I'll show you examples of, is quite important in terms of making sure that it's not too thin or not too thick, because it can actually affect your strain measurements. And then after you've done all of this, seeing whether it actually tracks and makes sense in terms of whether it's actually following the deformation or the strain of the actual heart. So if you go through a couple of examples, so I've got A, B, and C here, and you guys, hopefully you guys can be able to talk or tell me what's going on. So I've got 3 images here. I've got my 4, 2, and 3 chambers here. I'm going to ask you guys, in terms of the panel A, can I do strain on my 4 chamber?
Yes.
Ben behind me said yes, and yeah.
I'll vote yes.
And that's correct. Like, you've got a good quality image. You've got a good definition of your endocardium, and the strain can track. What about B?
So I think that the software was okay. So yes.
Yeah, sorry. Someone was going to say something on that. Yeah.
Some of the anterior and posterior wall near the apex is not completely captured.
Yeah. So what would you do in that case?
Just change the sector width, widen the sector width.
Yeah, you can do that. But now, I mean, you're doing this retrospectively, and you're doing this retrospective analysis. So you can't really go back and acquire the image. So how else can I do this? Or do I discard this and say strain cannot be done?
I mean, you could still you can still try, you can still attempt to track it. You can still try and get the right. I mean, the biggest issue in B is going to be having the appropriate wall thickness. You can see the blood tissue interface really well, and so it's going to be tracking out the wall thickness appropriately, which I'd still try. I'm not sure how else you can optimize it apart from the software.
Yeah, 100%. I mean, sometimes you can edge enhance certain on EchoPack particularly, and you can see if that improves. But what you can do is, I mean, yes, you can still use it as a strain, but what you can do is you can exclude that segment that you've said that you don't really have good enhancements. So you can exclude, you can get like probably 4 or 5 other segments of regional tracking, and then exclude the one that's where it's not really tracking at all in that case. And what about in panel C?
I think the danger in panel C is you've got loss of the blood tissue interface at the apex, and it's like two continuous segments, which makes it harder.
Yeah.
Again, you can do the same thing. You can try and manipulate the software.
100%. And so, and I agree with Ben. So in that case, in panel C, it's probably a bit more difficult. And so to measure strain in that segment is difficult, particularly since you've got the loss of the blood myocardial interface segments.
Can you use contrast enhancing agent to get better definition, and then use images from that to calculate strain?
Yeah, when you get contrast, it becomes tricky. It actually becomes harder sometimes to track the strain. So
the software struggles to process
the software really struggles.
Okay.
But I guess in this case, a majority of the time, you're sometimes doing retrospective. I mean, not retrospective analysis of this. So then
it's all post-processing.
Yeah, post-processing. Okay, that was supposed to be deleted, but okay. All right, so I've got panel A and panel B in this case. This is a different strain package, or it's probably different strain package. What is the issues, or what is the difference between panel A and panel B in terms of strain tracking? Actually, which one do you guys?
Panel B is tracking the pericardium, so it might be inaccurate. So panel A might give a better representation of strain.
Yeah, 100%, and you're quite correct. And so, you know, the region of interest is actually tracking some of the pericardium, and you will get a different strain. So when you do strain measurements, it's quite important to make sure that you don't include any of the pericardium, because as you can see, if you include the pericardium, which is was panel B before, you get a lower GLS. Where in comparison, where you actually do it, where you're tracking the endocardium, you actually get an appropriate GLS measurements. And you can see that one of the curves is not that great as a result of that. So one of the practical consideration is making sure that, you know, particularly in the apex, that you're tracking the endocardium and not the pericardium. Okay, so what's the issue with this?
This looks like a 2-chamber image zoomed in, and panel A, I might be wrong, but it looks like it's tracking the papillary muscle. The image looks slightly off axis.
Yeah, 100%, and you're quite correct. I hope you guys can all see that. So this is where some of the papillary muscle is being tracked. And the problem with this is that it will give you an exaggerated motion of that segment. And so then it's going to give you an incorrect or representation of your strain. And panel B is the actual appropriate representation of that. So you can see that if you include the papillary muscle, you get an abnormally elevated or better looking strain because of the motion, of the excess motion. Whereas in the appropriate segment, the strain is actually reduced. So that's one of the important things. So being aware of what you're contouring and what's being included will actually make a difference in terms of how you do the strain analysis. Okay, what about in this case?
So panel B, or the one on the right hand side of the screen. So you've taken your infraseptal marker down, so you're encompassing the septal annulus, the medial annulus, the mitral valve.
Yeah.
It's down too low. So.
Yeah. So your basal septal is actually quite low. You've extended it right below the mitral annulus. And so you can see, like in panel A, you've got the curves are all relatively aligned and matching together. Whereas in panel B, you've got this, the yellow line, hopefully, I'm not sure whether it shows on you guys, but that represents this. And it's not really, like, you've gone way below the mitral annulus. And so making sure that when you actually choose, and it's just highlighted there in yellow, that in that case where, like, as Ben said, you've gone right below. And so that will be represented in your bullseye plot as an not deforming as appropriately, and so therefore, like, or not contracting at all. And you might abnormally think, oh, hang on, there's something going in the infraseptal region where this, and it's something abnormal, but actually you're not tracking the region of interest that you're looking at. All right, what about in this case?
Again, it's similar errors on the previous one. The trackings, including the left ventricular outflow tract and beyond into the aortic root. Exactly
right. And you're 100%. So in panel A, actually I'll go to panel B. That's where normal in a 3-chamber view is. And then in panel A, you've got where your strain region of interest, you've gotten into the LVOT region and actually aortic extended further. So, you know, in this example, you've got tracings of the anterior septum goes beyond the basal septum, which includes the aortic root, which will create like an exaggerated, like similar to before, septal bulge or region of interest. And sometimes that will artificially can reduce your strain, where if you actually did the region of the correct strain measurements, then you'll get a more reflective reflection of your strain. Okay, so hope that makes sense so far. Okay, what about in this example? I had to think about this.
The region of interest. The top one near the apex, it's going out of the window.
Yeah.
Difficult to interpret that part of the information.
That's good. You said something about region. I agree with you, Ravi. You said something about region of interest.
Yeah, it's narrower in the left lower corner image. I don't know which one's the better one. Maybe the one with the bigger region of interest will be more.
So I'm not sure whether you guys have heard, but there was a point made whether there's an issue with in terms of region of interest. One obviously looks narrower, the other one looks broader. So then the question, you know, and you can see the strain is different, -14 versus -16.7. So which one is the correct region of interest?
-16.6.
Why? Sorry, Ben said it was 16.6, the bottom panel.
Yeah.
And I'm questioning why.
Which is fair enough.
I don't know.
So the reason I say that is because I'm just trying to visualize it without the straining software at the top. And the region you've got there in pink seems to be moving better on like your visualization than what the speckles are tracking. It looks like it's thickening better. Now that might be a bit off axis with the views. There might be like posterior wall coming into play. I don't know, from that sort of apical segment there. So, but that would be my guess.
Yeah, I mean, you guys were pretty close. This is quite an important point in terms of choosing your right region of interest, and that means in terms of the thickness, because when you do the strain calculations and strain measurements, you can actually make it quite thick and thin in terms of how much of the endocardium you want to include. The issue with this case is that in the top panel, the region of interest is way too thick. And the reason for that is it's
Yeah.
actually tracking some of the pericardium.
Okay, that's what's doing it.
And so that's where the
That's
issue
right.
is. And so that's why you'll get a falsely abnormal reduced strain.
Yeah.
And so making sure that when you do your strain measurements, that it's not too wide, because otherwise you'll include parts of your pericardium in your strain analysis, and it will give you an incorrect strain measurements. What about the opposite is in the case where you've got too thin? Because if you've got a nice thin one, like the one on the right-hand side of panel B, you won't track the entire endocardium and you'll get a falsely increased strain measurement. So region of interest is quite important because you need to make sure that you're tracking the actual endocardium. And so you can adjust the ROI by changing the width of that. We talked about, making sure that you're aware of the mimics of the past. The papillary muscle was one of them. Is that me?
No.
Okay. The papillary muscle, it can actually give you a hyperinflated, I should say, a strain. And so that, you might think, oh, strain is actually normal, fantastic, but you've actually included the papillary muscle, and so it can actually impact the way you treat. And so the issues with this then becomes like, well, why is it so important in terms of strain? Like, why does it matter if it's like, say, for example, -28 and minus, 19.4? The reason why is in some cases it actually impacts on the way we manage these patients. And I'll go through some of the clinical examples very shortly, or why, in what circumstances that it can affect. And you guys probably know already. But before I do, these are some strain. Sorry, Ravi.
Sorry, look, I have not seen much of tracking, but just in terms of, where you put the region of interest, does the machine make that band, or is it like tracing the endocardium and the machine makes a band, or do you determine how much width you include into the, region of interest?
Yeah, 100%. I mean, the machine is quite clever in terms of so when you do the track, when you choose your, let me go back, let's see, what's a good example? No, I'm just trying to see. Okay, let's do this, right? So when I've got a 2-chamber view, can you see my mouse by any chance?
Yes.
Yep. Okay, so what I'll do is I go click. I usually start from the basal septum or basal inferior septum, and then I click the segments. And what you do is you have dots, right? And these dots you're marking the endocardium and say, okay, well, I'm clicking, and so just tracing the endocardium, and then it will come out with this strain flow tracking algorithm and saying, well, actually, and then you look at the wave motions or the tracking motion, seeing whether it's actually tracking. And the thickness is usually set by the machine itself. And so you can adjust that on your ultrasound machine, or depending on what the machine is, or even when you do post-processing to make it thinner or thicker, depending on, if for whatever reason the machine had made it too thick or whatever, and it's tracking the endocardium, you can adjust that. Or sometimes it's too thin and you've got an actual, a hypertrophied LV cavity, in which case then you can adjust and say, actually, I need to include a bit more of this myocardium, and as a result, or for whatever reason, it's not tracking properly, and then you can adjust the ROI or region of interest to change that to yourself. And then if for whatever reason, like for example, in the case where you've in this case, say I've included the papillary muscle, it's like, oh, hang on, I've made a mistake here. I can readjust and move this a bit further out, and then to get a more representation of or accurate measurement of the strain itself. And for example, then for the initial example where we talked about, I can still do strain, but it's not tracking a certain segment. In which case, then, for example, let's say, for example, the pink segment is not tracking well. in that case, I can just click on the pink segment and it will exclude that as part of the measurement or algorithm as part of when you do the strain analysis. So it will only include the other 5 segments and exclude the pink segment, if that makes sense. Hope that helps. Hope that makes sense, Ravi. And then hope that's where it is. I would say, like, when you guys, yeah, sorry.
Sorry, Shanthosh, one more question. So when you do the final, like, final analysis or final picture, how much do 2 people agree on the, placement of
Good question.
on the band or, thickness? That's very subjective again, isn't it?
Yeah, that's a good question, and people have looked into this in the past. So there is a learning curve with GLS and strain when you do this, because even now, like, when I do strain, I get one of my professors who looks at my strain and says, oh, actually, I would have just changed this, adjusted this, I've changed the region of interest. And the only way you can come across this or improve this is by doing more and more strain. And they've come at a magic number of about 50 strain measurements before you become more consistent with someone that's of an expert level. So doing more regular strain parameters, and what you'll find is when you're doing strain and doing the analysis, the other thing I look for is look at the curves. When I'm looking at the curves, if they all align, then say, oh, hang on, it actually is a representation of the actual GLS and measurement. If for whatever reason I've done a strain and I've accidentally included the infraseptal region, and I can see the yellow bar is actually not tracking at all with the rest of the strain parameters. So then I go back, re-edit, and adjust that, if that makes sense.
Okay, thanks.
Not a problem. So if almost get the answers away. All right, I'll just finish off with this final one, and I think Sam Ord has some questions for you guys after. So this is just 4 examples of bullseye pattern of clinical strain patterns that you may come across in your practice. Can anyone tell me what bullseye pattern is in the example A?
I'll go first. That's easy. Amyloid.
Damn it, that was the one I knew.
I'm not
cherry on top.
Cherry on top. Yeah.
I'm not sure whether you guys heard. It is cardiac amyloid. And this is a typical cherry on top pattern where you've got hyperkinesis of the LV apex and hypokinesis of the basal and the mid segments. And the reason for this is because you've got a lot of infiltration of the amyloid proteins, resulting in restriction of those patterns or a reduced strain. What about in terms of panel B?
Is that 10 at the septum? It is, isn't it? Those numbers are 10.
Mm-hmm. Yes.
Maybe like an infarct or something, or some kind of ischemia.
Septum's down.
Septum
is the base.
Regional, like, sort of change.
So, points have been raised whether it could be an infarct. Anything else? Have a look at the
B mode image. It's pretty chunky.
It's pretty chunky. Okay, yeah. So this is an example of hypertrophic cardiomyopathy where the strain is reduced, but it's a bit abnormal to get regional strain variations because generally strain overall in HOCM is reduced. But that's why it becomes a bit more difficult in terms of just basing this on strain, because sometimes they could have LVH and amyloid as well as part of their thing. What's the difference? What about in panel C?
Akotsubo?
Not quite. In Takotsubo's, you get this blueberry on top pattern, like you get in cardiac amyloid, where you got the cherry on top, but you get this blueberry on top pattern.
Look at this, the beam made image. I mean,
yeah. What about the
whether that's thrombus or something sitting at the top of the apex?
Could be apical hypereosinophilic syndrome.
Yeah, Hatem, you're quite correct. So it is a variation of HOCM. It's the apical HOCM. It's a bit difficult to see on the echo to still image, but you've got reduced strain in that segment in comparison to the rest of the segments. And what about the last segment?
Is that blue brick?
Look at the myocardial.
That's cheap.
Yeah.
Quite thin.
Yeah.
So yeah, it's
Cold
thin.
infarct.
Yeah.
And it's
Okay.
aneurysmal.
So one of the things that was raised is like, having a look at the image, the apex looks quite thinned out. Obviously, it's associated with reduced strain in that segment. So, one of the things that you would consider whether it's an apical infarct.
Okay. Can I just pick on Ben just a little bit?
Yes.
He says aneurysmal, right? What's the definition of aneurysmal?
So aneurysmal would mean that during systole there is contradictory, there is outgoing motion
Fair
of
enough,
that
fair
region of tissue.
So if there's outgoing motion, do the speckles come together or do they go apart?
They'd go further apart.
Far apart, right?
Yeah.
So
So you have a positive number.
exactly, and here you can see that it's white, so you've got a negative number. You see it says -3, -2,
Yeah.
-4, whatever.
Yeah.
So it would have a positive number, and
Yeah.
that would mean it'd be going in the wrong direction. So that's where it would be blue.
Yeah. Yeah. There's a sniff of blue there under the negative.
I couldn't see back there. You're right. There's a sniff of blue, sniff of
All
blue.
right.
It looks pretty white from back here.
So I'll hand over to you. Do you want to?
Yes, I just maybe just questions. We'll go through some DDU questions at the end of this, not related to this talk. But did anyone want to ask any questions for Shanthosh?
Shanthosh, can I ask, and I acknowledge that we've got
The guru here.
Associate Professor Ord sitting right next to me. How much work of this, because obviously you come from a cardiology background, and in the critically ill there's less strain stuff done, generally speaking. In the everyday in and out of the clinic cardiology background, department, does everyone get strained? Do you do this to every patient, or you just do to like the chemo-oncology patients, or those with maybe early stage diastolic dysfunction, or is it just, it's like a part of your default scanning for everyone now?
Yeah, it's a good question. It depends on where you practice and what the values or the practice of the institute are. So generally now at Nepean, all, if not most of the patients will get GLS strain as part of their assessment for LV function. If you particularly, and this is particularly because we get a lot of patients who got who've got cardio-oncology patients, and I haven't gone into this in detail, but like it's a bit later on, or pulmonary hypertension patients, where strain actually makes a big difference in terms of how we assess and manage these patients. So one of the issues, and strain is particularly important in terms of cardio-oncology, is because the subtle changes that you get early on in your myocardium as a result of the toxicity from your chemotherapy is not picked up by either visual estimation or your 2D Simpson's biplane images, because they're quite crude measurements as such. And so strain has the advantage of actually picking up those subtle changes much earlier on, and particularly in between the cycles when they've got 2 or 3 or 4 cycles, that you can actually measure the subtle changes. So if anyone has a strain initially before chemo of -20 or whatnot, and then the next 3 months later they're -16, that perks our ears, and we're like, hang on, this patient needs to be closely monitored on a 3-monthly basis. They need to be considered in terms of cardioprotective agents, because if the LV goes down, it may preclude them from further chemo down the track. And so you really want to prevent that, because these guys really need their chemotherapy. So in that case, or in our practice, all of them actually get GLS.
Yeah.
And it takes about extra minute or two once you get quite used to in terms of measuring them. But we also start doing quite routinely 3D or 4D LVEF as part of the practice.
And do you do RV free wall strain as well as part of routine practice?
So RV free wall strain is not usually as part of practice, but if, for example, if I'm looking at pulmonary hypertension, or I've got a pulmonary hypertension clinic, that'd be more that'd be routine practice in that circumstance.
Yeah, cool. Thanks.
Yes, Ravi.
Does it show anything about diastolic dysfunction?
Yeah, Sam, you can probably allude to that in terms of.
Yeah, I guess there's a pretty big paper that's done from a lady called Gloria Landsberg in the critically ill looking into this. The short answer is yes, they can use what's known as strain rate, and you look at the E wave of that. I don't know if you've shown the graph.
I haven't gone through the graph. Yeah.
So when you're looking at strain rate, which rather than looking at the actual sort of absolute value of the change in the deformation, It looks at the rate of the change of the deformation. So that's why it's called strain rate. And that strain rate looks a little bit like an upside down tissue Doppler imaging curve, where it goes down during systole and then up for the E wave and up for the A wave. And you can use what's known as the SRE, which is the strain rate, the early strain rate, I guess. And Gloria used that over E prime. So instead of using the E over E prime, she used the strain rate E, and she estimated that was the most accurate way of assessing it. That has not been validated, just like every other diastolic function thing in the critically ill. And then there is some cardiology literature where they suggest that the SRE may actually be the most sensitive marker for segmental, segmental diastolic dysfunction is the most sensitive marker for ischemia. But I think, these are single center studies done by enthusiasts in small patient numbers. So the long and short of it is, yes, you can get it, but it is a long, long way away from being validated.
Thanks.
Hattem?
Thanks, Santosh, for that. Sorry, I missed most of the part, but just a quick question. Something that I started using recently, and I'm not sure, would you have any idea about it, which is the left atrial strain?
Yes. I've gone over it only briefly because I didn't want to bog you guys down in terms of left atrial strain. We use it now more commonly because it gives us a lot of information in terms of how the LV behaves or how the LV functions. Now, Sivapathan, who did a lot of work on left atrial strain, and Lisa Thomas at Westmead, these guys are phenomenal guys in terms of, oh, now I've frozen it. It's frozen on this picture. These guys have done a lot in terms of left atrial strain, and the reason for that, oh no, it's shut down, sorry. And left atrial strain actually measures the function of the left atrium. So the different parameters or different segments can look at the reservoir, conduit, and contraction function of the left atrium. And so it gives us a lot of information as to how the left atrium functions, and also in terms of how the left ventricle functions as a result of that. I'm not sure whether you've wanted to add anything else instead of left atrial strain, but
I think it's an interesting measure. It's a marker, you said, of left atrial function. It also gives us an idea of sort of like what the reservoir function of it is in terms of, particularly the size and how it changes during atrial systole. There's not a lot done in the critically ill. We're trying to have a look at it. It's touted as being the most sensitive marker of atrial function and most sensitive marker of acute raised left atrial pressure. So it's got some, I think it's got some real prevalence potentially in the septic cardiomyopathy literature.
100%, but Hattem, even now in our clinical practice, or in clinical echo routines, we don't use them. Well, I don't use them routinely in terms of assessing left atrial function. But if someone has, it's been validated or it's been looked at in terms of people who've got cardiotoxicity, but also in terms of stroke. And I suspect left atrial function is probably going to be part of our risk calculations in terms of whether this person is at risk of stroke down the line. We've got our CHADS-VAS score and whatnot. And I suspect that left atrial function is probably going to be included at sometime down the track in terms of that.
Do you have any cutoff point to identify normal from abnormal? Because I struggled to find any real reference.
Yes,
there is. So the paper by Sivapathan in JAC goes through the normal values.
What were they? Obviously, we remembered it because we've read that paper a lot. I can't remember it either.
Yeah.
Oh,
what does your PhD supervisor say? Supervisors say.
Hattem, I can send that paper to you.
Yeah.
That would be great. Thank you.
We should really know that off the top of my head. I do hope he never watches this.
Yes, Ravi.
Sorry, one more question.
100%.
When we give a number for strain, is it calculating all the radial, circumferential, longitudinal for that area?
No. So the number that you get when you do your assessment, it looks at global longitudinal function only. So it looks at the GLS only. So that number -20 or minus 15 or whatnot, that looks at global longitudinal function of your LV and you know, or if you did RV per se. If you want to do radial strain or circumferential strain, you have to do it off post-processing analysis, and there's usually a table that comes up with strain, and I always have to go back in terms of, because there's a whole table that comes up, and you try and I always have to figure out which table value actually measure circumferential and radial strain. But the number that you get as overall is GLS, and that's global longitudinal strain.
And just to clarify, the actual clinical utility of circumferential or radial strain, my understanding is it's not done very often. It doesn't have much of a role that we know about at this point.
Yeah,
compared to longitudinal.
100%. So global longitudinal strain has been validated in a lot of disease states and has been prognostically shown to be important as a marker. So that's why we measure it. Circumferential and radial strain, there are some constraints, particularly in terms of the application. It has been shown to be, there's some variations in cardiac amyloids or any infiltrative diseases. And there's some pattern differentiation. But to be honest, in terms of routine practice and in terms of communicating that to even non-cardiologists, we don't talk about circumferential and radial.
So the only pathology that I know where the circumferential and radial strain's been very useful has been constrictive cardiomyopathy.
Yeah.
Just getting research work showing differences between the septal versus the lateral walls. I don't think it's been shown to be of utility in the critically ill, because it's pretty hard to do, and it's certainly not as well validated as longitudinal. And I'm sure Shanthosh went through this, which is the longitudinal is the one that's been validated and looked into the most, because that's where the longitudinal fibers are on the inside, the subendocardial layer, and that's the one furthest away from the epicardial coronary arteries. So they're the ones that get affected most by early ischemia, and that's why longitudinal strain has theoretical benefit over circumferential, which is more about those, what do you call them, oblique myocardial fibers.
Yeah. Okay. Any other questions, guys?
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.